Okay, we are going to go ahead and get started. This is a session on suicide assessment using the Columbia Suicide Severity Rating Scale screener version. And you will see that sometimes I mess up my acronym, including on this slide, now that I notice that I have two C's. And it's actually just one C. So it's the Columbia Suicide Severity Rating Scale screener version. So it's a lot of S's in there, and sometimes I forget exactly where they are. But we're going to cover some of the pieces around suicide that are required, at least in Minnesota, for teacher relicensure, to make sure we handle those. And then we're going to talk specifically about how using this tool. I think I have a slide in here about this. And then through some of the sticky situations that we encounter in school. I will try to keep a look at the chat, but like I said, I'm doing this by myself today, so I don't know for sure if I'm going to catch everybody's questions. We do have a time for question and answers at the end. Feel free to put them in there anytime, but I may or may not see them. So who am I? Okay, before I do that, I'm going to just highlight myself here. Okay, there we go. I am a licensed independent clinical social worker in the state of Minnesota, and I have 20 years of experience working in a school setting. I actually started off working in early childhood with Head Start kids, and then jumped up to incarcerated youth, and have worked with a lot of youth that are at risk of dropout, and then also anywhere from early childhood to our 21 or older special ed students has kind of been, I've had some experience with. I also have a lot of experience at central office. So I have been a central office administrator now for over a decade. And so some of what I'm going to be talking about is my experience in helping counselors and social workers and mental health practitioners be able to navigate this at a district level. I also am an assistant professor at Winona State University in their MSW program. And then I have my own small business called Resilience Impact, where we do training and consultation, but primarily training for school districts and school employees. I'm licensed as a special ed director and superintendent, and mom of 4 and an old house lover. If you're looking for more training, like I said, this is what we do. We do one signature event called the Trauma Informed Schools Institute, and we do that every fall in Rochester, Minnesota, which is where I am based. And so that is coming up in November. And if you are interested, want to know more, there is the link. We'd love for you to check it out. We talked a little bit about the plan, so I'm just going to skip over that. I want to say, if anything today feels triggering or you're like, I just can't do this today, I'm sending you a recording for this. So please take care of yourself as you go through this. If right now is not the right time, or if the way I'm presenting information is triggering to you, please reach out, but don't feel like you have to be here to get your certificate at the end. I will make that available to you in other ways. There will be a certificate that I'll share with you at the end. But like I said, I'll also send out the recording and you can email me and I'll get you the certificate that way as well. So we're going to talk a little bit about how some student symptomology has changed over time. Again, you probably know this, but I just want to show you some data that probably highlights what you already know as practitioners. We're going to talk about how to use the Columbia Suicide Severity Rating Scale to assess suicidality, how to respond, and then thinking through some sticky situations together. So overall, big statistic, 1 in 5 children has a mental illness in the course of their childhood. I'm curious if that number is higher, but because that's an old statistic, but we know this is really common to students that we're working with. We also know that mental illness happens on a continuum, that we sometimes want, the way our medical system is set up is that it's like, okay, they met all the criteria for depression, check the box, or anxiety or whatever. But we all know that these things happen on a continuum, that a student may or may not meet criteria for an anxiety, some sort of mood disorder, but still be really struggling. My guess is that you've felt that in yourself, that it's like, okay, my anxiety is kind of kicking up. I'm feeling it more, but you might still be functioning okay and people can't tell. So you might not necessarily meet a diagnosis, but that does not mean it's not troubling. And it doesn't mean that it's something that you could use support in managing. So suicidality is also on a continuum. It's not like they are suicidal or they aren't suicidal. That's why assessment can be more challenging, is that you will often find that students are having some suicidal ideation, but don't necessarily are at high risk for a suicide attempt. We know that sometimes kids might tell you that they're feeling like they want to just not have to do it anymore, or I just don't want to go on anymore. But they yet aren't at the point, and hopefully they won't get to the point of feeling like they want to die or thinking that they have a plan. But it's still really important for us to pay attention to those earlier kinds of remarks and thoughts that kids have, because we know that this happens on a continuum. Okay, so this is a little bit overwhelming on this data, but I want you just to take a minute and look through this. And we're going to use the chat here to just comment on some of this data. Whoops. So you'll see that in Minnesota, for those of you that aren't Minnesota based, we do a triennial survey. So every 3 years, we survey 5th, 8th, 9th, and 11th graders. And we ask them questions about anxiety and depression, and also about suicidal ideation. So you will see on the left side here, your numbers from 2016, and then on the right side, numbers from 2022. So in the chat, what are you noticing as you look at this data? So when I think about diagnoses of depression, we're looking, the first one is really talking about anhedonia, when you just don't feel like you've lost that luster for life. The second one, specifically is asking about feelings of depression. And so if I look down at the nearly every day, because that would be kind of our kids who we would be thinking about having a diagnosis for. If you look at 11th grade females, you can see that there was a jump in those 6 years from 10% to 15%. Yes, Jane, I do see that males are doing better, right? We haven't seen the same jump in this data set in males than we did in females. The other thing that's interesting to me is if you look at 11th grade females, about on that last question, who's been bothered by feeling down, depressed, or hopeless, 46% of females in 2016 said not at all, never done it, down to 36% in 11th grade. So I do think that these feelings of being depressed and hopeless have become more common. Anything else you notice here? Boys, like my 12th grade son, will just quickly circle no to everything. That may be true, right? Yes, there are always limitations in our data. Yes, and we do have a culture still that discourages boys from identifying and talking about their emotions. Okay, one more slide like this. So this is 5th graders. So if we see, I sometimes feel bad without knowing why, strongly agree. We went from 17% of female 5th graders to 25% of female 5th graders. I worry a lot, strongly agreeing, 13% to 23%. Whereas we actually see the male students amounts, at least on strongly agree, going down. It is going up on agree. So I show you this just to, I think this audience knows that this is really common, that our kids are struggling with a lot of things. And just want to show that the numbers also back that up, that we are seeing increases and that this is very commonplace for our youth. So these are 2 slides that are required by to do a suicide prevention training. And so again, this information might be a quick review for you, but we want to be looking things in addition to the words that kids and the students are using. We want to think about what actions that we're seeing. Are they engaging in risky behaviors? Have we seen changes? Are they giving things away? Have we seen more negative self-talk? These are all warning signs that we want to be prepared for. Some risk factors that make students more likely in the research to be experiencing suicidal ideation and have a suicide attempt are a physical disability and illness, ongoing exposure to bullying, history of a mental health condition, recent death of a family member or a close friend, access to harmful means, previous suicide attempts. So what do you do if you're concerned? Again, I think this is probably a review, looking at in the chat what most of your positions are, but it's really important that we're asking directly the question, are you thinking about suicide? Have you had thoughts of suicide? And sometimes that can be a hard question to get out. It doesn't really flow right in conversation, but it's really important that we feel comfortable enough asking that question so that they can have a conversation. Often with suicide, there's kind of this shroud of silence that we don't talk about suicide. And it's important that we lift that and we be the safe person that they can have that conversation with, because things are always scary and more overwhelming when it's something that has to be left in the darkness. And so we want to be able to bring into the light, have a conversation, and be that person for kids about it's okay to talk about whether or not you're thinking of suicide. I have seen more willingness, and again, this might be girls, to talk about these things than I did 20 years ago. But I still think we have a long ways to go. I am currently in a doctoral program at St. Cloud State, and part of my research is around suicide. And one thing that I have found in my research is this interpersonal theory of suicide, which I found was really fascinating as I think about how we, the progression, I guess, to suicidal ideation and suicidal thoughts and behaviors. And this theory says that when there is thwarted belongingness, when somebody is trying to belong or has been excluded from a group, or they just don't feel like they fit in, along with perceived burdensomeness, which is quite the word, burdensomeness, where they feel like they're a burden to their family. My friends are, you know, even the teacher, you're nice to me because it's your job. I've been told that a few times by kids, like, well, it's just your job to be nice to me. When both of those are in place, this theory says that's when suicidal ideation would happen. And I think it's important in context of the training today, because we want to be listening for when these kinds of statements come up. You know, are they saying, you know, I don't feel like I belong? Are they saying my mom just wants me to graduate and get out of the house? The teachers have to be nice to me, it's their job. You know, when you're hearing those kinds of things, I think it's important to ask about suicidal ideation. So walking through this area, when those two are in place, then suicidal ideation happens, when they're having ideas and thoughts around committing suicide. In order for a suicide attempt to happen, this theory would say that there needs to be acquired capability. So when there is exposure to dangerous things or death, there's kind of this sense of, as humans, we're kind of wired to kind of fight death. And as there's more exposure, some of that kind of breaks down, and that's where you get a suicide attempt. So some of the examples that, like number one that stands out is in combat. when you've been in a combat situation, which we think about veterans, and they have suicidal ideation and that acquired capability when they've had those events in their life that have kind of broken down some of that mysteriousness or fear of death, is when you would get a suicide attempt. It also can be, like we know in the risk factors around a death of a friend or the death of a loved one, or a suicide that happened in your school. It also can be non-suicidal self-injury. So non-suicidal self-injury isn't always a suicide attempt, but when you have suicidal ideation and a non-suicidal self-injury, it can make them more likely for a suicide attempt. Feel free to pop any questions around this in the chat, and we'll see if we can get through that. But we are going to shift and talk about the use of the Columbia Suicide Severity Rating Scale. This has been extensively used internationally across clinical, medical, and research settings. So this is not a school-specific tool. This is what they use in the emergency room all over the country. This is what some of our police officers, at least in my community, have been trained in. It's a widely used tool, translated in 103 languages, and can be used across the lifespan. I think technically it goes down to 4. So if you're working with kids younger than 4, I think you can think about these questions, but asking them in the language is not appropriate. It's available in 3 formats. The Lifetime Recent Clinical. So if you are a clinician and want to see that, you can Google that. All of this is available online. There is also a pediatric version that is longer. We're going to talk about the screener. I think the screener is sufficient for our work as school employees, and it's pretty easy to use. We are going to watch a short video about this. I'm worried that I didn't say share sound when I went to share. So I'm going to stop sharing quickly. Oh, share sound. Optimized for video clip. Okay, we're going to see if this goes. Will you guys let me know if you can hear it in the chat? Well.
If they had a behavior, it was predictive, and if they had both, it was 2 times as predictive.
Mm-hmm.
Suicide is a major public health crisis. It's a leading cause of death across the world, across ages. It's an incredibly prevalent and devastating public health issue. And there's no way for us to prevent if we can't identify. We know that 50% of people who die by suicide see their primary care doctor the month before they die. We should be asking these questions the way we monitor for blood pressure. The Columbia Suicide Severity Rating Scale was developed in the context of a national trial to meet this great need in the field that hadn't been met before in terms of how to best identify people at risk.
For the first time, and as long as anyone can remember, we may be actually able to make a dent in the rates of suicide that have existed in our population and have remained constant over time. And that would be an enormous achievement in terms of public health care and preventing loss of life.
Used to be in the past, somebody would only get asked about a suicide attempt. And then if you just ask about that, you miss the person that bought the gun yesterday or put the noose around their neck and changed their mind. These are things that we cannot afford to miss. So covering the full spectrum was of critical importance. When people give you certain answers about what they've been thinking, like they might intend to act on their thoughts or they have a specific plan and some intent, we know that that actually can predict at this point who is going to go ahead and try to end their lives.
The benefit of this is that in emergency rooms, in clinical settings, in schools, in primary care offices, this can be used by doctors and medical professionals or people who are trained in it who don't have any medical training at all previously but are trained in the use of the instrument. This can be used to screen individuals And then if they reach this threshold level of concern, to refer them for further evaluation and possible intervention.
So at the end of the day, it's about saving lives and better directing limited resources to the people who actually need them.
Let me get back to my slides here. Whoops. So that video just provides just a short overview of the tool. And so I'm going to put in the chat here, again, the link to the Columbia Suicide, the actual tool that we're using. And then I have to, present, here we go. And I had a printed off copy of that, which I now don't know what I did with, so I'll just read it on the screen. You can see it's short. There are 6 questions, and depending on, and it's asking for symptoms within the past month. So the first 2 questions are asking about suicidal intent. And then, so you ask questions 1 and 2. If 1 and 2 are no, or if 2 is no, then you go directly to question 6. So these first 5 really are about suicide intent, and then question 6 is asking about suicidal behavior. Questions 3 to 5 are asking about the intensity of the ideation. So how intense is their ideation? So let's talk about the first 2 questions here about intent first. Have you ever wished that you were dead or wished you could go to sleep and not wake up? So this is kind of the kind of a general question, kind of an opening question. And then have you actually had any thoughts of killing yourself? If you get a yes to that question, then you're going to go into the, let me go back, sorry, into these questions about the intensity of the ideation. So I want to talk a little bit about suicide attempts as defined through the Columbia, because it's a little bit different than what maybe I think of or what I was trained. So suicide attempt in Columbia, and I think overall in suicide assessment practice, is if there was any action or behavior that had the intent to die, even in part, then it's considered a suicide attempt. So let's talk through this example. Student wants to get out of the house and away from her abusive mother. The student takes 6 ibuprofen after researching a lethal dose. She is transported to the ED, her stomach is pumped, and she's admitted to the hospital. So again, this takes some clinical judgment to be able to look at and kind of determine whether this would be considered an attempt. In this situation, she researched what a lethal dose was, which is higher than 6. And her intent was not to kill herself. Her intent is to get out of the house and away from her abusive mother. So while this, if you heard, what happened, like she's in the ED, she had to have her stomach pumped, there might be kind of this predisposition to think, okay, that was a suicide attempt. But in actuality, according to the way this tool teaches this, is that it isn't. Because there's no intent to die, then it can't be a suicide attempt. Let's talk about the next one. A young woman, after a fight with her boyfriend, feels like she wants to die. She grabs a knife and creates a scratch, and then she changes her mind. So I'm curious in the chat, what do you guys think on that one? Would that be a suicide attempt? Great. Okay. Yes. Yes, it would be, because even though the chance of the lethal means of it was very minimal, right? She wasn't going to die from the scratch. She did the action with the intent that she wanted to die. So even though, I mean, even if there is no injury, it's not about the injury, it's about the intent of the individual, because this still puts this individual more at risk for a future suicide attempt, even though there was no injury. Yeah, she had the intent, but she changed her mind. Okay, last one. Child was feeling ignored. She went to the kitchen where her mother and sister were talking. She takes a knife and cuts her wrist. She denies wanting to die, but wanted attention. Would that be an attempt? Right, not an attempt, because she, even though, you know, maybe there was a horrible, you know, there was a lot, if there was a lot of blood and there was an injury and like, it looks like a suicide attempt, but it's really important to be able to assess what the intent was of that individual. How about this one? High school student cuts their wrist after a fight with their boyfriend. We don't have enough information in this situation. We need to be, somebody needs to be able to talk with her to find out what her intent is. I think we assume it was an attempt, but we want to be able to gather more information about what her intent was. So going back to the screener and how to score it. So if you have you wished you were dead or could go to sleep and not wake up, and if they say yes, you're going to put it in, you're going to mark that an X right here in this first box. I see your question, Angela, and I would assume it was an attempt unless you have information, you know, unless they're telling you no. Have you actually had any thoughts of killing yourself? If they say yes, you would put a mark there. So right now, if you go down here to the bottom of the screener, you can see that, okay, they're kind of meeting the criteria so far for low risk. So let's go to the next question. Because they said yes to number 2, we would ask number 3. Have you been thinking about how you might do this? If they say yes, puts them at moderate risk, right? They're in that planning phase. Even if it's, you know, like just a couple of thoughts, it puts them at a higher level of risk. If they say no, then the highest level they would have checked so far would be low risk. So if they had answer yes to 4 and 5, have you had thoughts and some intention of acting on them? And have you started to work out the details of the plan of how to kill yourself? A yes in either of those would be high risk. So even if you've asked 1 and 2, they say yes, you get to number 3, they say no to all of the intensity ones. And then you go down to number 6. Have you ever done anything, started to do anything, or prepared to do anything to end your life? If they say yes, we want to know if it was in the past 3 months, which would put them at high risk. And even if if they've ever done it, right? If they've ever started to create a plan, it still puts them at moderate risk. So you can see here that if they have some suicidal ideation and a past plan, they're going to stay in that moderate risk area. Even if right, the risk is reduced, this screener will still show that that they're still at that moderate risk. So this is really only a screener. It gives us our kind of first look. It guides us through some questions. It helps you be able to talk to another provider in another setting as a school person, and make sure that we ask all of the questions that we need to. But this is not the end of the assessment or the end of, it's like, okay, well, they were high risk, right? There's still a lot more to work to be done in order to be able to create a plan to help keep them safe. Okay, this is a video that shows this officer having a conversation, and he walks through how he has how he kind of works these into the conversation. So one piece of feedback that I get with the screener is like, okay, these questions feel so formal, and like, what am I supposed to do? Just get out this piece of paper and like ask the kid? And no, you don't have to read from the piece of paper. You also might learn these questions. It's not too hard to kind of gain some familiarity. You don't have to ask them word for word, but it follows a progression that can help train so that everybody's doing this the same way. So I just want to, I like to show this video because it shows kind of how he works it into a conversation with this woman. I wish it wasn't a police officer, but this is the video that I have been able to find. So we're gonna watch this. I think it's about 3 minutes. And we'll come back.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself. So I was dispatched to her location. I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to CSSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm gonna ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that, all right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Okay, were you scoring that? Where would she have came up on the scoring? I didn't tell you to do that, but just curious if anybody was. Can I share the links again? Yep, here we go. There's the link. Low. Yeah, let's go back and look at it real quick together. So, have you ever wished you were dead or not be sleeping? She said yes. Have you actually had any thoughts of killing yourself? She said no. So then they skipped 3 and 4 and 5 because there was a no here. But then on 6, she said, that it was not in the past 3 months. So I agree that it would be more in the low to moderate range. So definitely we're concerned about her. But the fact that she hasn't engaged in any planning lowers her risk. So I would encourage you, if you want to try using this tool, I'd encourage you to just have these printed out and on a clipboard somewhere in your room or however you want to do it. The one that I shared with you is a PDF fillable, but I think it's helpful to just have it printed out somewhere or on a little card of what the questions are so you can pull them out. You don't have to pull out the form in front of the student. And in fact, I would encourage you not to do that. I would practice how do we kind of pull these into conversation? And I'm sure that most of you are having these kinds of conversations already with students. So how do you weave these into your conversations? I think it's also okay sometimes to say, oh, I'm worried about you and I want to ask you a series of questions just to see, to kind of assess how much I need to be worried about you. So you have to know your students, you have to know how to use this, but you don't have to pull out the form and go, okay, question 1. It doesn't have to be that. A lot of this you can gather from conversations with the student, and then you can go back and kind of like, ooh, okay, I want to score this based on our conversation, and you'll be able to do that. Would it be possible to move the black square on the screen? Is it up on the top, Sarah? Oh, I know what it is. It's my meeting chat. Okay, well, maybe that made it go away, but now I can't see you in the chat. So hopefully that worked. Okay, threat and suicide. This has been confusing sometimes, so I like to talk about it in this training because sometimes the two can get confused. So suicide, the risk of harm is focused on self, and it can be premeditated or spontaneous. In our school districts, we have also developed a threat assessment process, and when there's a risk of targeted violence towards another individual or a group of people, we wanted some way to respond to those situations. However, the responses are different. They are different plans, different assessments. And what was happening after we introduced this was sometimes there were situations where an individual or student was having some suicidal ideation, and then it was being assessed through the threat assessment process because they were saying that there was a threat of violence to themselves. It's important that we make, and the assessment didn't make sense. There are situations where you may have need to do both a suicide assessment and a threat assessment. That's not uncommon, but we need to understand that they're two different assessments, two different kind of processes that we're going to go through. So again, suicide, we're thinking about I don't even like to use the word violence because I feel like that confuses things, but it's the risk of harm when they're thinking about themselves. Threat is when the risk of harm or the risk of violence is focused on another person or a group of people. It's a targeted threat, not just a reactive behavior. So the other thing that would come up sometimes is that sometimes we will have students that will make suicidal comments in the middle of a behavior or an outburst. They sometimes will also make comments towards other people. I am sure you're probably, I don't think we're alone in our students, that it may be like, I want to die and I want to kill you, in some version of that in these reactive outbursts. We absolutely want to assess for suicidality, not in the moment, but when we're able to de-escalate and be able to repair and have a conversation with that student, even though it's reactive and it was kind of maybe said in a way to, you hear it said, oh, it's there to get attention, or it was meant to get a response out of you, or they were just trying to get out of something. I don't care. It's still, you always still have to assess for suicide. And you want to be able to come back with that student and say, you said this and I'm worried about you, so I want to follow up with that about that. It doesn't matter if we think it was for attention. It still is something that we need to be concerned about and that we need to be able to take seriously. On the threat assessment side, again, we want to always assess. We want to be able to ask more questions, and we're not talking about the threat assessment process today, but at your schools, I think it's also important, in addition to what you're thinking about developing a plan around suicide assessment, to also think about behavioral threat assessment or threats of targeted violence. And do you have a team? Do you have a process? Do you have a tool that you're using to be able to assess that danger for that student and your community as well? This is just a flow chart kind of that has been helpful. So, because sometimes when students say things, it can sometimes be like, okay, which process do we use? And so this was something I had developed, that if they indicate they want to harm, and sometimes we really have to tease out, is it towards themselves or is it towards others? If it's towards others and it was reactive, we want to ask them about it. Most likely it's going to be providing support to that student. If it was targeted and they, so this is the situation where usually it's not in a reactive situation. They're not just saying this because they got mad at you and they were de-escalated, but they, something becomes clear, or they say something and it seems like, okay, they are thinking about something, they have a plan, or they have an idea of trying to get back at somebody, hurt somebody, make a name for themselves. That's when we want to refer it to that building threat assessment team. If the harm is directed towards self, we're going to screen for risk using the Columbia. If it's high risk, we're going to do immediate action and safety planning. And if it's medium or low risk, still safety planning and ongoing support. So considerations when you're working in schools. I encourage you to let your administrator know. You don't need permission. I mean, I think most of everybody in here is in a certified role that if I remember, kind of the most of you would consider yourself mental health professionals, and you have an ethical responsibility to respond to what kids say and assess for suicide. So to me, I don't believe you need permission, but it is nice to loop your administrator in, especially if you're going to be calling families, just letting them know, I did a suicide assessment on the student. This was the results. This is what I need from you. And just letting them know what's going on. Another thing that you can do, which most of you are probably aware of, but is asking for a welfare check. If you do a suicide assessment and you have a plan and they don't then come to school the next day and you're worried, using your resources and thinking about how do we go out and do a welfare check. In my community, that is through our 911 number we can call and request. It could be through your school resource officer. It could be through a community safety officer. Just know in your community, how do you request a welfare check? Differentiated responses. When I first started working in schools, there was some leadership that felt anytime we did a suicide assessment and there was any risk, we had to send them to the emergency room. Everybody went to we always encouraged going to the emergency room. And I remember I was working with a 5th grader and I wasn't part of the team that did the assessment, but he was in the next morning and he came in and he said, my mom is so mad that we had to sit in the emergency room last night for 5 hours and they didn't do anything. And I'm never going to tell you again what the thoughts I'm having. And that sometimes people need to be in the emergency room and we absolutely need to send them. And the reality is they might have to sit there for 5 hours, but we need to make sure that who we're sending to the emergency room is appropriate, because it sends a message of don't tell me what's going on. And that was the message this kid got, is like, every time we respond, instead of thinking about a plan that's appropriate for that situation and that child, is we have this kind of one-off response that every time we do this, we as professionals need to help guide that team and think about how do we together come up with a response. What is the most appropriate response? How do we bring the family into this? How do we help create safety? Who do we bring in? And that requires some work. I get that, but always sending to the emergency room, regardless of level of risk, is not an appropriate response. Storage of documents. This is a tricky one. And I encourage you to talk about it at your district. Whether you want this in a student's cumulative file, I don't feel super comfortable with that. I don't also feel very comfortable with it just being in your desk drawer and you throw it away at the end of the year. So is there another place in your system to think about how we store health records? Can it be scored similarly to that? How can we meet the requirements of FERPA, but also protect the confidentiality of that student? If you are billing Medicaid for services that you provide in schools, you also have to think about HIPAA applies. And so there's a lot to consider there, and I do not have a good, simple answer for you, but it's something that you'll need to think about when you're going through your process. Family notification. Families should know about your assessment. I know that there are, again, some sticky situations where that can be difficult, but as a general rule, we want families to know they have to be part of the safety planning for that child. And how do we help engage the student in that process? What do they feel comfortable with? What can that notification look like? Who can be their support people? But it's important that we also are letting families know. So I want to talk through some sticky situations. I'm going to check the chat real quick here. Awesome. Okay, Miguel, thanks for answering that question. So what if the student makes suicidal statements every day? I've ran into the situation where it's like, okay, are we supposed to be doing a Columbia every day? Maybe. I mean, I don't know if you have to get out the paper, but I do think that it's okay to go back with a student and say, okay, I heard you say this again. I just, every time you say this, well, I'm going to check in with you because I'm worried about you and I want to make sure that we are helping support you as you're struggling with these thoughts. Sometimes it feels like the student, it might be saying it just to get a rise out of the adults or to somehow maybe manipulate the situation. And like I said before, I think we err on the side of assessing and providing support. You can do this Columbia, especially if you just did it yesterday, very quickly. Unless I would say you could do this in 2 minutes. Like, okay, we're going to talk about these questions again. And we're looking to see if anything changed and have that conversation with them. I think that's the right response. I know there's always individual situations, and as a team, you need to talk through it. And I would encourage you to do that. What if my admin or SRO reports that they already assessed the student for suicidality? As a mental health professional, I don't feel that my admin and SRO that I have worked with have the same credentials and knowledge and expertise to assess suicidality. And I feel like it's my ethical responsibility to have a conversation with them. You may have SROs who are trained in the Columbia, and then you have to kind of manage that. So that's why these are sticky situations. But usually I would want to have a conversation with them as well. What if the student states they don't want anyone to know? I think you know the response to this, that this is one of the areas where we must break confidentiality if we feel that it rises to the level that they are in danger of hurting themselves. That's a little trickier when they're at that low risk, like they're having some suicidal ideation, but they don't actually have a plan. They don't have any attempt. So if they're just feeling like, I just can't go on any longer and I just want to die, kind of that question one, but then they say no to the rest. To me, that's a little bit trickier. And I'm not here to give you all the answers. I think you have to look at that yourself. Clearly, we, in most situations, build safety for a student when more people know. But we also have some students that are in really complicated or difficult situations. And so as a team, this is where you are, as a provider, this is where you want to have some consultation. This is where, is there a team that you can talk to? Is this a situation that would be appropriate to talk to your admin? Is there a supervisor you can talk with? I don't think it's like an always, especially when they're at that low level, especially if the student is really agreeable and agrees to be forthcoming if things are changing. What if a student has a school-based mental health therapist on site? What if they have a therapist in the community? Should you still, as the school person, be doing that assessment? And I would say yes. I mean, if they're in front of you and you're having a conversation with them, it doesn't take long to talk through these questions. I would go ahead and talk through them, get the student's permission then to follow up with the therapist that they're working with or whoever else needs to know this information. But I would err on just having that conversation. And again, asking the question, when we leave talking about suicide in the darkness, when it's something we can't talk about, we increase the chance that there would be I don't know if I don't want to say it that way. I think that we create safety when we bring things into the light, when we're talking about it, when we can have an open conversation about it. Are there other sticky situations that you have had that you want to put in the chat here? Check on our time. Yeah, we're doing great on time. Okay, Lydia, I see your question. In our district, we utilize mental health therapists from agencies who do assessments. If a student has a plan, they are sent to the hospital. We have had students who have been adamant about not going to the hospital because they have been before and didn't think it was helpful. What do you do in these types of situations? This is tricky because it sounds like you are working with an agency, right, that doesn't have a differentiated response. I think what I would do, and I don't know if politically you could do this, but would be to have a conversation about that, and probably specifically about that situation. The student is feeling really adamant one way. How do we help have that student have a voice and be an advocate in their own care? If the family is feeling, can the family be in that conversation, and this other provider and yourself, and be able to have a conversation about, this is the plan we're going to, this is the steps we're going to take when this happens. This is the line where we think they'll need to go to the hospital. And before that, these are some other actions that we can take to promote safety. I think a lot of times providers want, it's clear cut, right? And sometimes in agencies and bureaucracies, we want to have like this one size fits all response that everybody goes to the hospital, right? We protect our own liability and everything goes. And it doesn't necessarily account for what's best for the student, what's the best for that situation. What are the logistics of your local emergency room? Like what do we expect them to do that we can't do ourselves? Are we just shifting that responsibility when it might make more sense if they're safety planning for us to do that at school when we see them every day? So some of that I think is localized too on what resources you have in your community. Is there some other type of crisis response that we could build in to that response instead of the hospital emergency room? When the student lies or doesn't seem forthcoming. Yeah, I think we keep trying. We communicate our care that we want to know. There are probably reasons why they are not being forthcoming. And so I think continuing to try, continuing to let students know that we're here. You're saying this, but I'm seeing some other things that maybe don't match up with what you're saying. And I continue to be worried about you, so I'm going to continue to check in. That them just saying no, I think about like at the beginning where sometimes our students are like, nope, just circling no because that's easier. I don't want to have to deal with this. Like you can still say no, but I'm still going to check in on you. So that shouldn't be the reason why. And that because then they know when they need somebody, okay, this person is exactly who I need to reach out to. Because there may come a day when it does become overwhelming and they can no longer just internalize that. What age is recommended for the pediatric version? So I believe it's 4 to 17. The pediatric version is the longer version. So I think it's more like 20 questions. So it's meant for clinicians, where the screener is meant for kind of everybody. The pediatric and the clinical version are meant for clinicians. So if you are a clinician and interested in looking at that, it's available online. There's training available online. Yeah, and I'd encourage you to check it out. It's a more in-depth assessment than the screener that I shared today. Yeah, it is really challenging when parents don't take this information seriously, and I think speaks to the importance that sometimes we can have as school providers to let kids know that we're worried and we are scared for them and we're walking alongside them in this journey. I think continuing to communicate. I think there's sometimes this general like feeling of, oh, well, they're just a teenager. That's just the way it is. And I disagree. I don't think teenagers should have to be depressed and suicidal, and we say that's normal. I think that's a really sad state because it's not normal. A student self-reports no suicidality via the CSSR and then reports otherwise to other adults and peers, erring on the side of caution and document that a child might be withholding information, like Sarah was lying. Yeah, I would agree with that. I don't know if I would state it as lying, right? That seems to kind of put a judgment on them that maybe they feel safe sharing with other people, and for whatever reason, no fault of yours, they don't feel that with you, or yeah, that students just don't feel the safety or the ability to share for whatever reason. A lot of times when people are struggling with depression specifically, some of your cognition is impacted. And so being able to make good decisions and process information, especially when it's only in your head, there might be a lot of reasons why students are not sharing, but continuing to follow up. Do children get sent to the hospital without parental participation? Years ago, I did make the referral and have my students sent before I contacted parents. I think always families should be involved before they are sent to, on an ambulance. I mean, one, it's scary for the child, right, to be sent on an ambulance, and having an adult that knows you and cares for you with you, I think makes that less scary. I think parents have the right to know, and that they should be involved. I think there also has to be parent consent. I know we've ran into this a couple of times too, about whether or not we feel they need to go. Families aren't taking it seriously, don't feel they need to go. And those are situations, unfortunately, where we have just used our school resource officers or police to help navigate that piece, because officers can do that without parental consent. I don't feel comfortable, even though maybe we could as mental health professionals. In a school setting, I just don't think it's the best way to move forward. Kim, or Leslie, sorry. We usually send the Columbia Scale to the crisis center. After hours and hours of waiting, the student says no to everything and the student gets no help. Then they return to school. What are your thoughts on this issue? Yeah, that's really challenging when it feels like it's more than what you can handle at the school level, or that's outside of your scope. And yet there's nobody else who's working, or they won't agree to any other services. I think we do what we can. And again, we continue to support that child. We continue to advocate with that family. But again, I guess it's within our scope. How are we able to support? And we, just like in other areas where we don't get to say who goes to see their pediatrician about an issue, or who it's outside of our control. So what do we have control, and how can we support within our limited resources? And it might not be what we think needs to happen. It might not be enough, but that is one of the limitations that I think we can provide. Student refuses to answer questions. I'm sure you have great ideas on Sarah on how to get kids to talk. I might see if there's somebody else is there somebody else they would want to talk to about those questions? Is there somebody else that, if it's not you, can you bring somebody else into that meeting who they would want to talk to, or they'd be willing to share with? Would they be willing to write their answers? Would they, and if they say no, then they say no, right? Like that is their right to self-determination. And I think you say, I'm going to follow up with you in a week because I'm still worried about you. And we'll see if anything's different there. And I might follow up a couple of times if, and either I think usually something else will come up, or maybe that situation you'll be less concerned over time. But I would think about is there any observation? Is there any other way to get data or information or be able to gather it that isn't a conversation with you if they're refusing to talk to you? Okay, it is 9 o'clock. I'm sorry I didn't get to all of the questions. I have this picture in here that I had it sitting out on my desk the other day, and this is me on the right and at my best friend's wedding on the left. And my husband was saying like, oh, you look so happy and you look so like young. I do. I have no bags under my eyes. I didn't know I ever had a time where I didn't have bags under my eyes. But I have this picture out and I saved this picture to look at regularly because this was right after the birth of my first child. I was dealing with horrible postpartum depression and was suicidal, and had decided in my brain without telling anybody that I needed to make it to my best friend's wedding, because that would be a really crappy friend thing to do, is to kill myself before she got married. And I didn't want to do that to her. So this had been the date in my head that I had been dealing with for like 6 months, that I have to make it till at least August 11th, 2000. And so I put this picture in here to say that it's not always what somebody looks like. You know, they can be smiling and still be really struggling. And sometimes you just have to ask the question. Nobody asked me the question, and I didn't know how to bring the conversation up. And so I'm thankful to be here today. But I look back at this younger version of myself and with gratitude that I made it to where I am today, and as my motivation of why it's so important to be able to have conversations about suicide.